I would say that the majority of my patients are not liberated. They're not radicalized towards fat positivity when they come see me. Most people have, sort of associate a visit to the doctor with an audit of their body size, and an audit of their body size is synonymous with an audit of their healthiness. And often, the first words out of somebody's mouth are like, oh, am I a healthy weight? Or is my weight good? Or I gained weight. How can I lose it? Like maybe there's sort of broader ways that we can look at what it needs for you to be healthy, and sort of some gentle curiosity about why they want to pursue weight loss, right? So I'll say things like, tell me more about what your goals are, or, tell me more about why it feels like you need to lose weight. And often people don't even know how to respond to this question. It's so humbling. Like, and they'll be like, well, because I need to lose weight. Like it gets circular, like really fast. Like,
right.
And I'll be like, well, why do you feel like you need to lose weight? And I'll say like, well, because I need to, right? Like my body, I'm too fat, or I weigh too much, or my BMI is too high. And yeah, sometimes I'll use the phrase like, I'm a body positive doctor, or I'll say like, I don't care about the number on the scale. Like I care about all these other things. I care about the blood tests that we're going to order. I care about your blood pressure, but I don't care about the number on the scale. And then people will say like, what, really? Or that seems scary. Like that seems dumb. Or they'll say like, I care about it. Like, even if you don't care about it. Right. And little by little, we try to sort of peel back the layers and undo some of the harm, but it's a long process, and it's not achieved in one visit.
I'm Cadence. This is Busybody Podcast, and I'm very excited to be talking to Mara Gordon, who is a doctor, and I'm going to ask her more about what that exactly means. But we were just talking off screen about pelvic exams. Finish what you were saying, and then we'll formally introduce.
That sounds great. Yeah, we just got into it, and we'll back up in a second to do introductions. But I was saying basically that like the idea that most people with a uterus need an annual gynecologic exam has kind of been debunked, and it's not clear that it really prevents disease. It's not really necessary to get a birth control prescription. It's not really necessary to like quote make sure everything's okay. It is necessary for a couple specific things, like if you're having an IUD inserted, if you're having pain, certainly if you're having symptoms, if you're having issues, by all means, like go get checked out. There's so many great doctors. But the idea that like everyone who's walking around with a uterus needs to go in and have a biennial exam, which is, an internal vaginal exam and a sort of exam palpating like the outside of the body to feel the uterus, ovaries, not really medically indicated. There's not a great evidence base for it. And it's really awful. Nobody likes them, right?
Nobody likes that.
Science, yeah. And for pap smears, I mean, there's a ton of science that's changing around cervical cancer screening. I have a lot of my patients who swab their own vaginas to check for cervical cancer, which currently, certain groups like the American Cancer Society says that I'm getting like deep into the weeds, but yeah, there's like not exactly consensus in the medical community about the best way to check for cervical cancer right now. I think it's something that's probably going to be changing a lot in the next couple of years, that the idea that you need a pap every year, that was when I was a young adult, I was like, oh, you're supposed to get a pap smear every year. Not true anymore. We have better testing. And I think it's really likely that testing is going to further evolve in the next 5 to 10 years, where people can swab themselves. They don't necessarily need a doctor to do it. So lots of changes in the idea of like sort of medical gatekeeping around our uteruses, right? That we need a doctor to like be the expert of your pelvis is kind of going away, which I think is great, because nobody likes getting a pap smear. Not a fun thing.
Wow.
So, yeah.
Wow. Mind blown. That reminds me also of when the HPV vaccine came out, and then it had an age cutoff or something. Mm-hmm. And then I have a more progressive doctor that I go to upstate. It's a clinic that mainly works with people who have like addiction, and like it's like pay what you can. Literally, I found it because my partner's old roommate used to work there, and I was like, oh, you can go if you're like a person who has insurance and can pay and all that kind of stuff. But because they work with addicts, what's very cool is they can't prescribe a lot of things that regular doctors can, which I find means that they're a lot. I mean, this is like a little bit of throwing shade, which I will be because I'm not a humongous fan of Western medicine. I found that they're a lot more creative because they can't prescribe addictive substances so easily. And so I just find in general, my conversations there have been like way better than in all my other years of going to doctors. And at some point I was like, can't I get the HPV vaccine? Because I miraculously do not have HPV but many adult women already have been exposed. Apparently I fought it off because one of my exes has it. But they were like, yeah, of course you can. Like, why not? And I was like, yeah, right. Like, why can't I just get it now? If I didn't already contract it, I should just be able to get it now, like in my 30s. And it was super nice. I just went in and got my 3 shots. I was like,
congratulations. That's really good.
I don't have to be a 14-year-old girl to get that.
Totally. Yeah.
For this weird idea that I'm married off already or something.
Totally. Yeah. When it was first approved, I mean, I think if I'm remembering correctly, I think it was first approved for girls only. And that.
Yeah,
really
exactly.
There was a lot of outcry about that. But yeah, so good. I'm so glad you got vaccinated.
I tell people all the time, like if I meet someone who's an adult who doesn't already have it, I'm like, you can just go get the vaccine. You don't have to be 20 years old. Totally. Get it when you're 45, get it whenever. Well, let's formally introduce you. What is your exact title?
Of course. Thank you for having me. I'm a big fan of all the work you do to make movement and just to make movement accessible to people of all different bodies, shapes, sizes, types. Love it. So my name is Mara. I am a family doctor in practice in Camden, New Jersey. I actually live in the Philadelphia area. Camden's like 15 minutes away. And I am a primary care doctor to both adults and children, which I love. And I do a lot of teaching. I teach medical students, and I'm also a writer. And I write a lot about size-inclusive medicine and fat-positive medicine, which is what led me to your work, because I feel like it's so inclusive of, just so many different types of bodies. And I love it. I think exercise can be for everyone, or movement can be for everyone. And that's sort of the framework that I think about in my practice of medicine too.
So I wrote all these questions out, and one of my first things that I wanted to ask you, I literally wrote out, I've never been super into Western medicine, but I'm also not about to steam my Yoni. So I'm not so far away that I'm like, steaming my Yoni instead.
I was like, wait, what's steaming a Yoni in your face? Yeah, I got it.
I'm not like
not my favorite. Yeah.
Yeah, I'm not the like white woman yogi thing where I just like I'm gonna heal everything with turmeric powder or something. But I also, for a zillion years, I never had a primary care doctor. And basically in the pandemic, I rewatched all the seasons of ER. Spoiler alert, they get so bad towards the end. It's very unfortunate.
I've never really been an ER fan. I was really into Grey's Anatomy before I went to med school. But then once I went to med school, I was like, I can't. No,
yeah, I imagine.
It's real life. So,
but ER
medical dramas these days. Yeah.
There are so many episodes where someone comes in and they're like, my shoulder hurts. And then they're like, you have 3 weeks to live. But if you'd come in earlier, we would have discovered it and you could live. You only need to watch a few of those episodes before you're like, maybe I should get blood work done. So
I'm glad.
So after that, I was like, I should get a primary care and just go in and get full blood work and like all that stuff. But explain exactly what a primary care doctor like what's the role? Because I've been thinking about this and I've been like reading what you talk about and I'm like, what are doctors? Like what is the primary care versus why do I go to my primary care and tell them every single issue I possibly have? Like that just seems like a lot for one person.
It is, but that's what we're here for. I mean, Cadence, that's such a good question. And I honestly don't think I know the answer to it, despite doing this all day, every day. I mean, I think there's a lot of questions within that question. So I think, at its most basic, right? I think a primary care doctor is like a first line of defense for both treating you if you get sick and also helping you be well. Yeah, treating if you get sick and helping you be well. And so the first piece of that I think is a little bit easier, right? So like, a primary care doctor is sort of like somebody who hopefully knows you, right? Who's met you over time. I mean, I have some patients I've been caring for years. I have families I take care of, which is so fun. I love, I have babies, adults, grandparents, like the whole fam comes in together, which is a little chaotic, but also like really rewarding. Yeah, like I have twins who come in together and I'm like, oh my gosh, I can't tell you apart. I'll have to be like, okay, this one, this one. And we have lots of good distraction techniques for our rooms full of children. But yeah, so I like, if you like hurt yourself while you're jogging, right? Or you get a cold, or all of a sudden you develop headaches or, diarrhea or whatever, right? That like, we're sort of like a first point of contact who can help you like think through how to approach that, whatever sort of is acutely bothering you. And then I think a second layer of that is also like we treat a lot of chronic disease, right? So I manage people who have a lot of chronic illnesses like high blood pressure, coronary artery disease, people who have diabetes, things like that, right? That aren't necessarily emergencies. Hopefully we catch them before they become emergencies, and we can treat them appropriately and manage them so that they don't become emergencies. And yeah, so primary care doctor sort of over time can help you treat chronic illness, right? And then the third layer, which I think is the most complex, I think this is where we as a sort of field and maybe just the US healthcare system fails the most, right? So ideally, people can sort of see a primary care doctor as an ally, as sort of like a navigator of understanding, what screening test should I get to make sure that I'm staying healthy, right? Like, how do I screen for cancer? How do I screen for high blood pressure? How do I screen for depression, right? And those are things we do in my office. If you come see me, we're going to be talking about age-appropriate cancer testing. We're going to be checking your blood pressure. We're going to be checking in about your mood. And I think that's where we as a field really are not doing a good enough job. And the reasons for that are very multifactorial. I think, the US healthcare system is just like very reactive. Like we respond to crisis, right? Like that's how we're just set up in every corner of the US healthcare system. It's how we set up payment. It's what's incentivized, right? Like the sicker our patients are, the more money doctors make, which is really problematic. And we're also, just so profit driven and, corporate and capitalistic as a industry, right? In ways that I think are profoundly harmful and really are making me lose the trust of my patients, right? When people get a bill when they see a doctor, like, of course it makes them not trust doctors, right? So I feel like we as a field have so much work to do, but those are very systemic issues that sort of make it difficult for doctors to act as like, really sort of partners in wellness for our patients rather than like reactive treatments if you get sick, if that makes sense.
It's so interesting because I always think about like, it used to be that the doctor showed up at your house with their black bag, and that would be such a different relationship. Now you've really got like, that feels like an ally. And also obviously the doctor is seeing your home life and like, it's a whole different thing. And now like, I never experienced a doctor that came to my home, but no one likes going to the doctor. I don't think. Maybe some people do. But like, it's like I'm waiting in a waiting room. I'm sitting in a cold office with a gown on. Like, there's nothing fun about this experience. And people are so lucky when they find a doctor that they really connect with. I have some older clients that have doctors they've been seeing for 30 years who are about to retire. Their doctor is 80, and they're like, I don't know what I'm going to do without them. They've seen them forever and they really have great conversations and connection. It certainly shouldn't be so rare. You're also making me think there are so many parallels in anyone that's like, client or patient centered in any kind of health care. You're screening for such a wide, from cancer screening to depression. That's like these are like extremely different and that's such a wide scale of looking at the person in front of you. And in my own work, it made me think of back in the day, we had a client who was a professional comedian and like TV writer and coming in for back pain. And one of my instructors was working with him, and they would do, for like half the session, they would do like breathing and meditation. And this guy was coming in for back pain, but he was so stressed that his teacher realized we need to address this, and just had skills in like meditation work and breathing. And he also is a performer. And so I'd look over there and they'd both be like, laying down like with their hands over their eyes, like so cute and very effective for this client. And in my work, I also have to be really nimble in like what a person needs and kind of scan for like, they can say, I'm coming to you because my elbow hurts. But then when we start meeting, there's clearly something else that's like more up. And before we get to that, we need to address this if they're open to that. And I think that's like the complexity of working with humans. And I think also the negative in a lot of the medical world is not seeing the human in front of you, no matter what they say, just being like, well, we're just doing this test. That's what's happening today. And they're like, excuse me, I'm trying to tell you this whole story. And certainly, yeah, I just feel like you only need to have like one or two times where you just get completely ignored by a doctor to really not want to go that route.
Yeah, I respect that. And it's hard. I mean, I have a lot of patients who have had a lot of really awful experiences with doctors. And yeah, I mean, I do my best to sort of undo that work and hope that I'm not perpetuating it myself. It's tricky, right? And I think, I think at the root of it is just, I feel like modern medicine in the United States has just gotten so corporate that we have just very little time with our patients, right? And that's not an excuse. I mean, when I work with students, like, we talk about learning communication skills that we apply even, when we have 15-minute appointments with our patients.
Totally.
So I think, I think the onus is on us to do better, and also the onus is on us as doctors, to do advocacy work, right? To try to make our system more functional. But yeah, I mean, I think just the core that I come back to over and over again is just like the system is not rewarding sort of cultivating deep and meaningful relationships. Right. The system is rewarding high volume, right? Like the more patients we see, the more we're rewarded for it. So
which is so interesting.
It's horrible. Yeah.
Yeah, because we also all know that health improves when people have community, when they feel like they're being listened to. Like hopefully people have also had the experience of finding someone who finally hears you or is like, okay, I'm putting all the pieces together with you. And you're like, there's such relief, you're like, oh my God, finally, like, this isn't just my burden anymore. And like that in itself makes you start to feel better,
And that's such a nice way of putting it. I love that, right? That it's like a doctor is somebody who can sort of, share a burden with you and help you navigate a burden. And, sometimes it doesn't happen on the very first visit with the doctor. In fact, it's quite rare, right? Especially for people who have really complex or poorly understood diagnoses, right? People who have
women.
So, right. As rare species.
Exactly.
But yeah, I think that like, particularly people who have diagnoses or syndromes that are hard to classify, or, like the science just doesn't really understand what's going on. Those people, it often takes a lot of time, a lot of visits, a lot of trust building to feel like you have an ally. Like it's too complicated to solve in one 15-minute visit, right? Right. Yeah.
How did you become, or do you call yourself like a weight neutral doctor or fat positive or HAES, or what's the?
Yeah, that's such a good question. So I am involved in an awesome organization that, all of your listeners, I would love to check us out. It's called the Association for Weight and Size Inclusive Medicine. And we're a brand new professional society for healthcare providers who are interested in providing size inclusive care. And we have been debating the terminology. To be honest, as a writer, I think words are really important, but I'm actually a little bit agnostic about this just because I think it's such an exciting and in some ways marginalized part of medicine, right? Like this is like not what we're taught in med school, right? So I'm sort of like, let's all get under one big tent and build community, even if we're using slightly different terminology. So I don't really care. And I have friends who are just like the most compassionate, kind doctors who are like, oh, I don't know if I meet criteria to be a health at every size doctor. And I'm like, it doesn't matter. Like, as long as our patients feel welcome by you, to feel like you're not stigmatizing them, like it doesn't matter what you sort of label yourself. But I sort of gravitate towards size inclusive. And I've actually sort of started embracing fat positive too, which feels super radical and more positive too, which is fun. But yeah, I mean, I think at its core, I always define it this way, which is a little bit tongue in cheek. I don't yell at my patients for being fat. Right.
Yeah, I mean,
it's like, let's set the bar really low.
Yeah.
Yep. And that to me is like the core of it. And I think it's just a testament to how ingrained a sort of like weight first approach to medicine is for just so many doctors. And I really think it's what we're taught. It's what we learn in school. It's what is systematically emphasized in a lot of different ways in the way that we bill for services and how we get paid, the way that like the computer systems that we use are set up. You know, I mean, it's really a systemic phenomenon, right? And so taking a stand against that is in some ways really radical, but it's also
I think it is, yeah.
Yeah, because people are ready for a change. They're just sick of doctors being jerks to them. So that's why we're here.
I mean, it's radical. I do a post every time I go to the doctor and am reminded of this. I'm in a straight size body and to help people, I refuse to get weighed when I go to the doctor or anywhere. And even in a straight size body, I get all these like looks and pushback and this and that. I literally went to an allergist this summer and they were like, step on scale. And I was like, that's okay. And she looked at me, she was like, yeah, exactly. And she was like, it says I have to in the chart. And I was like, I don't know, make up a number. What does that have to do with my sinuses? Like, I was just like, that's, what are you going to learn?
Yeah, totally.
And even,
yeah.
I mean, just to say more, like, correct me if I'm wrong with your medical knowledge. This almost brings us back to like the old timey family doctor who's not lugging around one of those giant scale things. What are you learning from weighing a person that you can't see with your own eyes? Because what I always think is like, I've never been to this doctor before, order my chart from my old doctor or whatever. At some point, there's my weight on there. If I walk into my doctor and I've seen them every year and I am 60, 80, 100 pounds more or less than I was before, hopefully they're using their eyeballs and they're like, hey, how are you? I noticed that you look a little different than last year. Is everything going okay? Feeling good? You know, like they don't need to, because I had a gynecologist 1,000 years ago that the first time I went to her, I got weighed. That summer that I got weighed with her was the summer after I had lost a bunch of weight that I gained when I very first started my studio, was incredibly stressed out, literally stopped exercising, stress eating constantly, put on weight, lost that weight. And I think, you know, just because of intention trying to lose weight, got lower than ever before. It was fine. It was healthy. I was like very focused. And then I just kind of was like, well, that was that summer. Went back to my normal weight. So balanced back out. Of course, that low weight was on my chart because I was just like, the summer went in. For years afterwards, she would be like, just so you know, you're like 15 pounds heavier, or like 10 pounds heavier. And I was like, lady, I tell you this every year. That was one summer where all I did was like focus on my health and my diet and my exercising all the time. And it was a really chill 3 months business-wise. So I had time to do that. We got to let that go and like literally use your eyes. I'm healthy. I'm feeling good. Like, what are you gaining from telling me this constantly? And it's literally one of the reasons that I just stopped going to her, because I was like, I'm tired of having this conversation. I'm going to have this conversation with you the rest of my life. But like, is there a situation where you really need to weigh someone? Really?
So first of all, I'm sorry that you had that experience. Thank you for sharing that. I mean, it's not uncommon. And I think, I think what I'm hearing, first of all, is sort of like a failure of relationship building and communication skills, right? That like the way that she brought up your changes in your body size felt more accusatory rather than allied, right? And I think there are ways to like gently inquire about a change in a patient's body size that feel more supportive rather than sort of accusatory. And
I feel like she could have
that way to a lot of people. Yeah.
Yeah, and I feel like ideally if she was listening, and that's the thing, I just feel like she literally wasn't listening, she would have just made a note, not her real weight on that chart. You know what I mean? So it's the lowest weight she's ever had for me. She should have just made a little note, not her actual goal weight or healthy weight or weight that she's going to balance out at. Let's stop inquiring about it. Like, patient feels good. Whatever. I don't know what people's notes look like. But like, it was like she never updated the story. It's just every time I saw her, she brought it up. And I was like, lady, and I was just like I met you in a 2-week period where I was like really not bloated, basically. Like,
right. Yeah. And I also think that speaks to sort of like the systemic nature of fat phobia in healthcare, right? That it's like, I mean, just the way that we build the computer systems that we rely on so heavily, right? I mean, I joke that I spend more hours looking, or I don't joke, it's not a joke, but I spend more hours looking at my electronic medical record than my husband or my son, right? Like it's just, this is like so core to the way that medicine is practiced in 2024, right? And like we've set it up. So like the time that you said that there was like somebody who was saying, I don't know what to put in the computer. I mean, we have it designed so that there's not in my office actually, which is kind of cool, but like that there's like a hard stop in the computer system where, you cannot progress with the visit unless you enter a digit, right? And it can't even be like XXX, it has to be numbers.
Right.
Or like your doctor who like couldn't update the note in a way. I mean, again, this is not an excuse. She probably could have done a much better job communicating with you, right? But like that, there wasn't really a place to note like, that this actually isn't Cadence's like desired body size or whatever, or like a body size where she feels good and feels healthy. So yeah, there's a lot of problems just sort of like baked into the systems that we use. And that's why it's such a systemic issue, right? But I think our initial question was, do you ever need to get weighed?
Yeah.
And the answer is yes. I think that there's a couple scenarios that are highly specific. And I think we as doctors have sort of like everything has just become like a conveyor belt. Like we're trying to get as many patients in as possible, get them out as fast as possible. And so getting weighed has just become like part of this like routinized, like, this is what we do. We got to keep things moving, like get you ready for the doctor. Like the doctor's going to be mad at me. I mean, that's something I've heard, right? That like the medical assistant is. And so I think the routinization of it is really problematic. And I have patients who decline to get weighed, and that's totally fine. We talk about it. And I think it can be an extremely useful clinical test, right? But this is med school 101. This is what I talk about with all my students, right? You should never order a test in medicine that's not going to change the way you manage the patient, right? Like that's like, every test should change management is like a thing we always say. Like there's no point in ordering a bunch of labs if it's not going to change what you recommend. And having a patient's weight often does not change management, right? So I think it can be used much more deliberately as a clinical test in the same way that like if you're describing certain symptoms and I say, it seems like we need to check you for anemia, right? Then I would order a test for anemia as opposed to just ordering a test for anemia on everybody who walks in, which also, there's some debate in the medical world about whether or not we should be checking everybody for anemia. So I will just add that as a footnote that may change as sort of a science-based recommendation in the future. But that was just an example that came to mind.
Sure.
So anyway, I mean, sometimes people have conditions like heart failure where they can get overloaded with fluid because their heart isn't functioning correctly. And having an updated weight can give us a really sensitive sense of whether or not they have too much fluid on their body that can cause a lot of heart and lung problems, basically. If you're getting chemotherapy, a lot of it's weight-based dosing, right? Children's medications are weight-based. So like a kid's dose of Tylenol will be based on how much they weigh. I worry when people lose weight really fast, right? Like that can be a sign of serious things going wrong. So I want to know if they're losing weight really fast. So those are all scenarios where weight's important, but I think we need to be more judicious about using it as a clinical test. And also just like why do we, in my office, I mean, I wish we could change this. Like we have a very small clinic. Like we weigh people just in the middle of the whole place.
Right.
In front
Right.
of everybody. It's like a public process. People are like, oh man, I'm so fat today. Like in front of like all the other
Right.
patients. It's just like such a gauntlet.
Yeah.
And we need to do better. Right. So
It's the same. My main medical experience is having dogs, bringing them to the vet all the time. And it's the same thing. They always, they weigh the dog like in the lobby, you know? Also, why don't we use the same scale as dogs? Because they just have to stand on that big mat. It seems so much easier. But yeah, it's the same exact thing. You just do that little pause in the lobby, jump on the scale, and then keep going.
Totally. And just understanding that it's a really traumatizing experience for a lot of people and thinking about it judiciously, right? Like I have patients who are in recovery from eating disorders who we don't weigh. We just don't weigh.
Yeah.
And if there ever came a time when I needed their weight for some reason, we would talk about it and we'd make a plan to do it in a way that was safe and minimize harm. But yeah, I think it's become such a systemic thing that it's.
And I just think about like most women are recovering from eating disorders or essentially still have some kind of eating disorder. And very few people, and especially women who are so socialized for people pleasing, in a medical office, we already have this thing where we just like outsource. It's an authority. They've got a white coat on. We're in this, system. We're being told to sit down and wait. Okay, it called your name. And then you might not be prepared because you're already kind of flustered. A lot of people, and I hear this a lot from my clients when they go to the doctor, they kind of shut down and they don't listen. They're like, oh, I always get so flustered and I'm not even really present. They're not in an empowered place that in that awkward moment where the nurse is bringing them back and it's like, oh, can you step on the scale? They're not even potentially ready to be like, oh, actually, no, I don't want to. So they just do it. And then they're all like, why did I say yes to that? All this stuff. Obviously, if the whole process was more patient focused, where maybe they fill out a questionnaire when they come in that says, do you want to be weighed? Blah, 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 like just all these things so that that person has more time and space. Cause I always just think about like, so many people have trauma past, abuse past, eating disorder past, shame. It's very hard to advocate for yourself. It's just so hard. And I really am a jerk. Like I almost walked out of a doctor's appointment actually fairly recently because I don't like men and I don't like listening to them. And I really put off going. I was having gastrointestinal issues that were related to hormone stuff, but I thought, my doctor was like, let's just cover the base. Just go to a gastrointestinal person just in case. Let's just get some imaging or something. And I was like, I really don't want to because I know they're not going to listen to me. And sure enough, I went in and this guy literally was just like, you should eat bran cereal. He literally handed me a handout of like Post cereal that was like laminated. And told me that I should exercise more. And I was like, sir, I teach exercise for a living. And he literally just kept repeating himself. I was like, all I eat is fiber. That's not what I'm talking about. I was like, my doctor thinks it would be useful to just, and he was like, no, nothing you're saying needs any imaging. You should eat bran cereal. I literally started putting my coat on. I was like, peace out, dude. So glad I waited in the waiting room.
Wow. I'm sorry that you had that experience too. And I mean, thank you for sharing that because I think it's validating, I think, for a lot of people to hear that, like, it's a normal response and maybe a good response to be like, hey, okay, I'm going to go. Like, this isn't helpful. Yeah, it's so hard. And I think, I like to think that, most doctors don't go to med school to be jerks, right? I don't think most of us go into this field because we want to not listen to people and fat shame them and stuff. I just think that over time, we've ceded control of our healthcare system, right? And I don't need to absolve my profession of blame exactly, but it's like our environment is just so corporatized, so humanized, right? That I think it dehumanizes the people working in it too. And yeah, it's funny. I didn't think we'd be talking about, politics and stuff, but I mean, this is why we need a totally different framework, right? I mean, this is why our system is so dysfunctional. We need a completely, totally socialized healthcare system if we want to start repairing some of the damage that we do every day, right?
Yeah, and what I always experience is that doctors feel very siloed into their field or kind of what tools they have to work with. And so, yeah, this person was just looking at me. I think he probably, given where his practice is, mainly treats older people. And I was like, sure, they're loving your brand cereal, advice, and they're thrilled, but you're literally not listening to me and who I am. And so glad that your practice is thriving and you're treating all these retirees, but you happen to be the closest to where I live. And I think that is also where people end up going outside Western medicine to practices that do more dot connecting. And yeah, I mean, that's unfortunate. I feel like even I had a friend in high school who is Korean, and I actually visited her in Korea, and we went to one of her doctor's appointments because I was just hanging out with her family. And she was getting treatment for scoliosis, and we were just like at a doctor's office, but they also had acupuncture there. They had, all kinds of stuff. It was like a regular, teen pediatrician or whatever office, but they had other services that were like, I just think that would be so radical in an American doctor's office to have acupuncturists, massage therapists, like these other modalities to treat something, so that she wasn't, she was just here's all the different options that we can use.
Totally. And that, I mean, when you use the term like non-Western medicine, I mean, it's such a broad term. So, there's tons of different things that fall under that category with, in my opinion, sort of varying degrees of merit, right? I mean, there's sketchy supplements you can buy from some influencer that might call itself alternative medicine, right? But, massage, acupuncture, physical therapy, I mean, all of that has so much research to back it up, right? This is not radical practice. And I often recommend massage to my patients, but it's not covered by insurance, right? And that just, I just can't get over the idea that I can prescribe somebody, harmful opioid medications, and it will be paid for by their insurance, and I can't prescribe a massage to them, right?
Yeah.
And I'm like, well, if you have, $150, you could go get one, but sorry, most of my patients don't. And I think what you're describing does not sound radical at all to me. It sounds like common sense. And I love getting massages. They really help me with my upper neck pain and chronic headaches.
Stress.
But totally, yeah. But it's not something that we sort of conceive of in the realm of traditional medicine. And what that means is not that I don't recommend it. It's just that it's not covered by insurance, right? So people have these expensive costs associated with it when they're paying an arm and a leg for their insurance premiums too. So,
no kidding.
Yeah. But yes, I think, the term non-Western medicine is extremely broad, but I think there's so many things that fall sort of under that label that have really rigorous science to back them up. Tons of people find benefit from that. And I think we narrowly sort of exclude them and sort of have a very narrow conception of what it means to go to the doctor. And a lot of that has to do with how healthcare is financed and what gets paid for. Right.
Yeah. I'm using all this to move into our conversation about weight neutral or fat positive medicine. So I have another question for you. How do you define healthy? Because this is something I think about all the time and I keep wanting to write about. And it's something also I've seen on your writing, and I'll preface this by saying, like, it's a real thing when you're talking about fatness and fat positive that I just saw someone posting who's a fat activist. They were posting information that if people are fit, it doesn't matter what their BMI is. They don't have all these morbidity issues. And then she had a whole caveat that she was like, no one owes anyone fitness, like blah, blah, blah. I'm just putting this information out because BMI is still being used, even though it's like very debunked. And similarly, like it's very hard to describe health without it feeling like it's a hierarchy. And I struggle to define. I have my own kind of definition right now, but I'm interested to know, literally being a medical doctor, like, what do you describe as healthy? You have metrics, probably.
Well, I mean, yes and no, right? I think so. Yeah. I mean, I'll start with to address one piece of what you said, which is like nobody has a moral obligation to be healthy, right? And that's often called in sort of the fat positive world, like the idea of healthism, right? That it's like discrimination based on your health status, right? And this idea that we have like a moral duty to quote be healthy. And it's not a moral issue, right? I think that's, yeah, it's not a moral issue. But I'm a doctor, right? Most people come to me because they want my assistance.
Yeah, they want to be healthy.
Yeah. And I mean, I the further I get into practice, the more I just really don't think there is a way of defining it. And I'll give you an example, right? Somebody might find it healthy to run as a form of fitness, right? That they feel like their mental health improves. They feel like their cardiopulmonary health improves. Their joint pain improves. They sleep better, right? Like all the great reasons to run. And then you break your foot, right? And running is all of a sudden something that's healthy becomes something that is literally unhealthy, right? Like it's gonna mess up your foot if you run on it when it's broken. And so I think that our own definitions of what it needs to be healthy evolve throughout the course of our lives. They depend on our circumstances. And there's just like a million examples like that, right? Where like, you might consider yourself healthy if you engage in a particular behavior, but then the behavior might change its status in your life depending on your life circumstances, right? So like I have a 3-year-old and I did not teach him this. He learned at school, like he started asking me if stuff was healthy. He's like, hey, mommy, is pasta healthy? Or carrot? And he has this very rigid thing that he like picked up from his preschool. He's like, carrots are healthy and chips are not healthy. And he says, candy is not healthy. And I'm like, well, what's your favorite food? And he says, candy. So he hasn't yet absorbed the morality yet, but he definitely has learned like, our sort of traditional things. Yeah. Like, well, actually there's are not healthy. If it's the only thing you're eating, you're going to overdose on beta carotene and that is not good.
That's my favorite story.
What?
There's this weird TV show, I don't know if you ever watched it, called, it's like something like, it's literally one of those titles, like Weird Ways a Person Died or something. Oh. And they have a story about a guy who juiced carrots so much that he turned orange and then died of like liver failure or something.
Yeah.
I'm laughing.
And when you eat carrots, it's not good. It's not good for you. Right. So carrots can feel health affirming in certain scenarios, right? But they're not health affirming in other scenarios where they're the only thing you're eating. So anyway, I guess I sort of think of that in the way that we conceive of health in, an overall portrait, right? And we can conceive of it as like the absence of disease, right? So we have ways that we define different diseases. A lot of those are also less clear-cut than you might imagine, but at least we have some attempt at it, right? And we have debate in the scientific community about, how diabetes is defined, how high blood pressure is defined. And I'm not a relativist about those things, right? Like if you get a diagnosis of diabetes, it can cause a lot of problems in your life, right? And when my patients receive that diagnosis, like we work together to treat it. But that like a medicine to treat diabetes might be healthy if it's, helping reduce your hemoglobin A1C, which is like the lab test that we use to diagnose and track diabetes, right? But if you have kidney problems, some of those same medications may not be, quote, healthy, right? Like they actually become quite dangerous, right? So I'm humbled the more I get into practice, right? It's like, I've seen curves of like, professional, I don't know how to describe this in words, but like basically like over time as you gain experience in your field, right? That your self-identified knowledge is like really high, like you're 1 or 2 out of medical school. And, as I progress, I'm just like, wow, human bodies are so complicated. Human circumstances are so complicated. Like, I don't think there's one way that I can define what it means to be healthy for my patients, right? And I think this is where the work of Kate Mann, who we're both huge fans, and we were talking about how she was on your podcast earlier. Her book, she's a philosopher, for those who don't know, and her book called Unshrinking is about fat phobia. And she has some really useful philosophical thought exercises, which have really sort of transformed some of my thinking as a physician, right? That like, you know, she uses the example of base jumping, right? Like people aren't maybe
that's
like
it. I literally wrote that quote down.
Yeah, I mean, I as a mom, I'm like, if my child ever gets into base jumping, like, so yes, probably the moms of the base jumpers are yelling at their kids every day, being like, stop base jumping. This is not healthy, right? But we don't sort of conceptualize like high intensity sports as like unhealthy that require like surveillance and policing in the same way that like a fat person eating some Ben and Jerry's might be surveilled or harassed, like if they're doing that in public. But base jumping is like objectively a much less healthy behavior, right? It's much more likely to result in disease or death, and somebody needs that, right? So no shade to the base jumpers out there. I actually know very little about the field other than it sounds horrifying and my palms are sweaty even just like thinking about it. But anyway, I try to bring that framework as a doctor too. I mean, how do you think about it? Like when your clients ask you, like, is this healthy? How do you conceive of?
I love what you painted, which is like similarly what I wish I could get across to people too, which is like a nimbleness of looking at your behaviors. I have started to define healthy as just like vitality, basically, you know, like what is my vitality or a client's vitality? Because first of all, I work with a lot of people who have pain, and that's very interesting because people experience pain very differently, and it intersects with so many other things, their stress levels, their support, their just general disposition. Are they kind of a grumpy, bitter person, or are they generally like optimistic, you know, chill person? And so I had a older client that we were working on. She'd been really sedentary her whole life and pretty low condition, and we were getting her stronger. And a lot of it was educating her about like what her body was feeling. Is she sore or is it pain and all this stuff? And she was telling me that her back was hurting and, you know, we were working with it. And I said to her, you know, I'm just interpreting what you're feeling. I don't know really what your pain threshold is. Maybe if I felt what you were feeling, I would be like, oh my God, you know, like throwing myself on the floor. And she really laughed. I was like, I can only respond to what you're telling me. And so I think about that in terms of people's like health. Like, is what they're doing, is what I'm doing with them, are their actions supporting a general vitality? And that was an interesting example you gave of like someone who was running and then they break their foot. A big thing that I hear from people is like, I used to be able to do this, or, you know, I want to be able to do this thing that sometimes is like very in opposition to their actual current lifestyle. And my question is always like, sure, it sounds great to be the person who gets up at 6 and works out every day, but you're telling me that you have kids or you have an intense job, you often stay up late. Do you like your job? Like, let's start there. If you really like your job and it's exciting and engaging, and that means you stay up late a lot, that's already the cost benefit is the job benefit to you is great. Let's not now put this weird pressure on yourself that you have to get up and do this very intense thing that's pretty in opposition to that. That does not sound supportive to your vitality. Let's find a time during your day, during your evening where you can do movement and not like, you know, deform the other parts of your life that you are enjoying already, like that. And I think we're so binary in our culture. Everything is like all or nothing, that the idea of really being intuitive, paying attention to the rhythms of our lives, being like, oh, it's, you know, I'm noticing it's winter, it's getting dark earlier. I am much less active than I normally am. My poor dogs can like barely get outside because I would live on the beach in Brooklyn and it's been so crazy windy. It's like kind of inhumane to like bring them out in it almost. Yeah. And I'm thinking like, this is just a real limitation. It's just like a hard limitation. I'm trying, And so I'm like, how much am I willing to do to like, quote unquote, stay active without just adding stress to my life? Can I use this time in a different way that's creative, that's fulfilling, doing other things while still taking care of my body, so that I don't just basically add stress and like a feeling of like failure or shame, and also recognize like this will pass in 6 weeks and 8 weeks. The sun's going to start coming out later. It's going to, this isn't my whole life. And this regimented way that people look at their health, I have to eat like this every day. I have to do this every day. If I have some kind of disease, woe is me, everything is terrible now. We have these like very, very strict ideas of like what health is. It's challenging because it means when you are writing about it, I feel like I can't use that word because it's so loaded for people. So I'm really, that's how I get with like vitality. I was just like, I think when you use the word health, people really do think like disease-free, thin, stress-free. And that's like, who's that person? I don't know that person.
Yeah. And I mean, it's interesting that you say thin, because it's often like when we think of culturally, I think when we think of what it means to be healthy, it's often what's sort of visible, which is why body size is such a, my body size feels like so difficult to untangle from all of this. And even, I mean, I work with medical students a lot, and I think in medical education, we often have this like dichotomy between doctor and patient, right? And I even catch myself doing it to my own students. Like I sort of assume that they don't have any medical problems. So I'll say like, oh, if you took this medicine, like it would be fine because your kidneys are fine. And then I'm like, wait. I actually don't know anything about your medical history. How dare I? And I'm getting better at catching myself. But I think it's most of my medical students are in their early 20s. And I think we sort of associate like, youth with absence of disease. And I mean, I've heard horror stories of the way that body size comes into it, that like somebody will be giving a lecture and they'll sort of look out over the audience and say, well, you all look healthy, right? To the medical students.
Right.
So, like, you don't have to worry about this, which is totally inappropriate for so many reasons. But at its most basic, like, that person doesn't know all their medical histories, right? So I think that what we often conceive of as healthy is like what is sort of visible to the naked eye, and we associate that with thinness. But like, somebody could be working out, 7 days a week, and that can actually be part of like a really harmful psychological practice. And they're actually really
exactly.
unwell psychologically, right? And I also like what you said about like this too shall pass, right? About the cold winters on the, on the beach with your dogs, that maybe we can have sort of definitions that are cyclical or definitions that evolve with different, times of life. I think what helped, I mean, just a brief example that comes to mind, like when I was much in my early 20s and I lived alone, like what felt healthy to me was like planning tons of social stuff, right? Like seeing friends like 5 nights a week. And now that doesn't feel healthy. That actually feels really draining.
Right. Right.
Because I have a little kid and, I go to bed really, really early, which I also endorse. And so that like in a different season of my life, right, that a behavior that once felt really vital and felt very sort of health affirming now may not feel the same way, right? So, or just in winter, like give yourself permission to like move your body in a different way than what you do in summer, right? Like I don't swim in the winter because it's too cold.
Right.
And, so I think that these ideas can evolve over time, that they're not always quantitative, right? Like we try to quantify a lot of stuff, and they may depend on your particular circumstances. It's very humbling to realize like how complex we are and that we can't be reduced to just one number that will tell us whether we're healthy or not, right? And I think that's what we try to do with BMI sometimes, which is just so
for sure
so harmful, as I'm sure your listeners know. If they've made it this far, they know that BMI is kind of nonsense. So
yeah, and I think that brings another intersection in our fields where there's certainly a lot of really reductive fitness as well as medicine where, the quick fix idea, like that's because of capitalism, because of both of these fields being so influenced, so created in some ways or shaped by capitalism. There's the give me a pill to solve all my problems. And then there's the, give me the bikini body 12-week, $29 program or whatever, and trying to educate people to look beyond that is complex. And it's probably why we're both writing in addition, which brings me to my question that I was reading in one of your newsletters that you were saying that a lot of your patients don't know about HAES or weight neutral ways of looking at health. And what does that conversation sound like? Like that's so interesting, because if people are coming to me, they probably are already kind of pre-screened that they're looking to work out with someone who is not focused on weight and is like, body positive, inclusive. Every once in a while, it is funny. Every once in a while, I get some like totally random person who like, it's like they just didn't get any of the messaging.
Cadence, yeah.
Yeah. I literally just actually recently had someone who was like, well, I like lost a bunch of weight on this diet, like 10 pounds in a month, and I didn't work out because the diet said don't work out. And I was just like, oh my. And I literally just had to start the meeting. I was like, do you know like what weight loss is? Like, do you know like all this stuff? And I kind of was like, how did you find me? But anyway, what does that conversation look like when you have patients coming in really from this social perspective that we have that are probably just like, I want to lose weight and I'm not healthy and blah, 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 blah.
Yeah. Well, it's so interesting. I find myself with like one foot in the world of body acceptance, which is an amazing space. And I feel like I've built a really cool community of other doctors and folks from other fields, right? Like people from the world of exercise and movement, right? Psychologists, nutritionists, and philosophers. There's just like such a cool opportunity to connect with people online that is really awesome, right? And I've learned a lot from people in other fields. But I think, so I have one foot in that world, and then I have another foot in, I practice in a low income community of color. And I find that, like a lot of the online community of body positivity, like just sort of isn't making it to my patients. Right. And that's part of how I'm conceiving of this work. Like, how do we make it? I think it's a really reductionist stereotype to say that like body positivity is for white women. I think that's just false. And I think there's a lot of amazing activists who do not fit those categories. But I think the stereotype is like rich white ladies. And so I want to sort of undo that. I'm a white lady myself, right? But I think a lot of it is, it has to do with like patterns of how we consume media, right? Like so many of my patients have never heard of Substack, right? Like they use Instagram, right. But like, it's just like that there's these huge disconnects in the way that people sort of get fed material that like resembles material that they already consume, right? So that it feels like these big disconnects in like the work that I do reaching people like my patients, right? And like the work I do in terms of writing. And even when I write for mainstream publications too, right? Like I write a lot for NPR, and my patients usually sort of know what NPR is, but they're like, no, why would I listen to that? I would rather watch the local news. It feels more relevant to my life, right? Whereas I'm like, oh my God, I will never turn on the local news because it's so upsetting. Yeah. So I actually, just as a brief aside, I love local news, and I actually pay to subscribe to the Philadelphia Inquirer and the Philadelphia NPR. Local news is vital to democracy, but like the local TV news that is like, man,
right, that's like,
or like whatever.
Right, exactly. It's all, it makes you not want to leave your house. You're just like, apparently there are just holdups and car accidents like every 10 minutes.
Exactly. Yeah. So just caveat, love thoughtful, rigorous local news, which I pay for. But anyway, so yeah, I would say that I actually have a sort of a growing group of patients who seek me out specifically because I am a size inclusive doctor. And frankly, those patients tend to be different demographically, right? Like they tend to be privately insured. They have the ability to drive to a doctor, right? And not like, to take an afternoon off of work, which is really hard for a lot of my patients who work in Amazon warehouses or who work as home health aides, right? Like they don't get PTO. Anyway, so, there's some major disparities in like who it feels like fat positivity is for. And part of the advocacy work that I'm working on is trying to undo that sort of myth that this is like, oh, it's just about a size 16 white lady feeling comfortable buying like Madewell plus size clothes. Like, no. This is
Right.
this is about justice, right? This is about health. This is about access to, the tools that you need to live a healthy life. And so, yeah, there's that. But anyway, so I would say that the majority of my patients are not liberated. They're not radicalized towards fat positivity when they come see me. Most people have, sort of associate a visit to the doctor with an audit of their body size, and an audit of their body size is synonymous with an audit of their healthiness. And often, the first words out of somebody's mouth are like, oh, am I healthy weight? Or is my weight good? Or I gained weight. How can I lose it? Etc. So I'm like really in the trenches with this every single day. And, I can't fix it all in one 15-minute visit. I try to just plant the seeds of, like maybe there's sort of broader ways that we can look at what it needs for you to be healthy, and sort of some gentle curiosity about why they want to pursue weight loss, right? So I'll say things like, tell me more about what your goals are, or, tell me more about why it feels like you need to lose weight. And often people don't even know how to respond to this question. It's so humbling. Like, and
Seriously.
they'll be like, well, because I need to lose weight. Like it gets circular, like really fast. Like,
Right.
and I'll be like, well, why do you feel like you need to lose weight? And they'll say like, well, because I need to, right? Like my body, I'm too fat, or I weigh too much, or my BMI is too high. And yeah, sometimes I'll use the phrase like, I'm a body positive doctor, or I'll say like, I don't care about the number on the scale. Like I care about all these other things. I care about the blood tests that we're going to order. I care about your blood pressure, but I don't care about the number on the scale. And then people will say like, what, really? Or that seems scary. Like that seems dumb. Or they'll say like, I care about it. Like, even if you don't care about it. Right. And little by little, we try to sort of peel back the layers and undo some of the harm, but it's a long process, and it's not achieved in one visit, even close.
Yeah. With that, I was reading, you have people that are like, I'm coming to you because you're a weight inclusive doctor. Also give me an Ozempic prescription.
Yeah. That happened a lot, especially when I first started writing about this and like publicly talking about it. And at first I was like, hey, like, were you paying attention to what I was saying? And over time, I've actually come to realize why that's the case. And I think that I just think that a lot of people face discrimination when they live in bigger bodies, and they want to be free of that fat phobia, right? And they sort of see a GLP-1 agonist like Ozempic to be a tool to free themselves from that kind of shame and discrimination and bullying. But they also don't want to be yelled at every time they come to the doctor, right?
Seriously.
Yeah. So I think it is very common, and I try to approach it with gentleness and with kindness. It's tricky, right? And a lot of people feel shame for asking for them too.
Sure.
Which I try to undo. I mean, it's hard, but yeah, the feelings are just so fraught, and the discrimination against bigger bodies is so deep and multifactorial that, just reminding myself, like, just plant the seeds of curiosity about another way, but I'm not going to be able to do this all in a 15-minute visit. And that's okay. Right. I try to be gentle with myself too. Right.
I have questions just around all the GLP agonists. Is now any diabetic, is that going to be the first, do you think that that's going to be the first treatment protocol going forwards?
Oh, that's so
Or I guess any diabetic who's higher weight?
That's a good question. I'm not sure. I think, most professional society guidelines, right? Like from the Endocrine Society, the American Diabetes Association, right? Like there are all these sort of organizations filled with really smart people, also often lots of big pharma money, but also really smart people. And they write sort of guidelines that trickle down to primary care doctors like me, where I say like, I want to practice evidence-based medicine. Let me look up what the American Diabetes Association, the first line medication for diabetes has been, the entire time I've been in practice, is a medication called metformin, which is really inexpensive, really effective, really safe. And it really helps people lower their blood sugar. And right now it's so much cheaper than GLP-1 agonists that I sort of see it as unlikely that it will change like in the next year or two, that they'll recommend GLP-1s as the first line. Who knows? It's possible. I'm not sure. But right now, it's not.
Okay, that's interesting. Yeah, because I feel like that's often in the media how these are getting touted, like they're so good for you. They are fixing all these diseases. And now I'm thinking, does this mean that every diabetic person that goes in is going to be put on these drugs, which, as we also know, have a lot of side effects? So that's good to hear that there is a pre-existing drug that is cheap and effective. Because I just feel like, is this true? I have been noticing that I feel, did some metric get changed? So many people are like pre-diabetic now. Like, did they just lower the numbers so that more people qualify as being pre-diabetic? Or is it just that all my clientele is reaching an age group where people are like, oh, I just go to the doctor and I'm pre-diabetic. I'm all stressed about it. I'm trying to like change my, eat more fiber and stuff.
Right. Yeah. I actually just looked this up for a talk I was giving, and prediabetes is pretty fraught. There's not clear consensus about how it's defined between different organizations. And like the lab that my hospital system uses, like has a pretty low threshold, right? So like a lot of people are diagnosed as prediabetes and they'll get it on their, on the app, right? On the patient portal app.
Yeah.
Before I've even looked at the labs, like it'll pop up and it'll say,
which
you have
seems
diabetes.
Terrible.
Yeah, that's as an aside. That was a federal law, I think, changed that made it so that patients had to be able to access their labs like immediately, which I think is overall good, right? Like I think more.
Yeah, same. I've gotten just for like blood work.
Yeah.
Yeah. But then when you would see like like my vitamin D levels were low, and it was like this red line, and and I was just like, oh my God, is it like fatally low? Like I was like, why is it so stressful looking?
Yeah, and I think a lot of doctors were sort of freaked out about that at first, and there's a lot of paternalism wrapped up in that, but it's true. I also get a lot of panicked emails being like, oh my gosh, do I need to go on the keto diet because I'm have prediabetes?
Right.
Like, absolutely not. Don't do that. And like, if we just had a few minutes to talk about this, like we could unpack what it means. But anyway, it's pretty heterogeneous, sort of who is diagnosed with diabetes and who goes on to develop true diabetes, which there's more of a consensus about the definition of diabetes, and which is like a particular it's a hemoglobin A1C of 6.5 or above, right? And that has to do with sort of like an estimate of your blood sugar over time. And that, so prediabetes is basically pretty poorly understood. We don't really understand who progresses and who regresses and who stays in the prediabetes range for their entire lives. And I tend to, if patients really want to start a medication, we talk about that, and I don't think it's wrong to start a medication for prediabetes, but I don't tend to like jump to it. That as soon as you have a diagnosis, you absolutely need it, because I think there's a lot of ambiguity in how we define it and who's at risk for going on to develop true diabetes. But I wonder if a lot of this has to do with people want to be on GLP-1 agonists because they want to lose weight. And so anybody with any evidence of elevated blood sugar, it might be a way to get it covered by insurance, which again, I don't fault. I do it. If a patient really, really wants to be on a GLP-1 agonist for the pursuit of intentional weight loss, and they have a diagnosis of prediabetes as my lab, I'll use that as a qualifying diagnosis in the hopes that it will be covered by their insurance. And again, I think GLP-1 agonists are extremely useful medications. I've been using them the entire time I've been a doctor. They're not new. And I think a lot of the discourse around like, oh, are they safe? Are they not? Kind of misses the mark. Like, I think it's really likely that they're safe. I think it's really likely that they're extremely useful for a variety of medical problems. I just don't think they're going to cure our fat phobia, right? And they're not going to cure the way that we rank bodies and the way we have a hierarchy of bodies and the way we feel shame about bodies, right? Like they're going to make your hemoglobin A1C lower. They're going to protect your heart. They're going to potentially protect your liver, right? Like there's all these great things that they're good for, but they're not going to fix the fact that like you don't feel good in like a mini skirt or whatever, right? Like, and I think that's where I take issue is like we still have so much work to do culturally, and we're sort of grasping for this medical solution to what is a cultural problem, you know?
Yeah. And I've experienced a few former clients, some just like family friends who have taken some of these, and you're not going to look like a Kardashian. Like, I think
Right,
if the intentional weight loss thing, it's like you'll shrink or whatever, but this is a issue that comes up that I try to educate people about in terms of weight loss. Like, people, I had a whole reel that went crazy viral because I basically was just like, you're never going to be skinny, meaning like your body is unlikely to look dramatically different than it does right now just because body types are real. And like, you could conceivably lose weight and you could conceivably tone up, but are you literally going to look like the Wicked girls? No. Like, if you're 5'9" and like, just like a strong body type, like, no, you're not going to look like a little pixie person. That will never, ever happen. And I think people just constantly have this idea of weight loss as like, I literally will look like a celebrity, or I'll finally look like my cousin or whatever. And it's like, if you just never looked like your cousin, even when you were 12 years old, you just are not going to. And also, if you lose a massive amount of weight, you look like yourself that lost a bunch of weight. You don't look like yourself 15 years ago. You don't look like yourself after you trained for an Ironman. You look like yourself after you lost a bunch of weight, which is a different body than you might be thinking in your head. And I do worry that these drugs just feed into our just society's idea of like fantasy thinking around our bodies and our lives. My whole life will be better. I'll lose 50 pounds and I'm suddenly going to be driving around in a Corvette or something. Like, it's just like,
Totally. Yeah. And that's what I feel so uncomfortable as a doctor, right? Is like, that's not what I went into medicine for, is to peddle,
right.
Snake oil, right? And I did go into medicine to prevent my patients from having heart failure exacerbations, right? And GLP-1 agonists can help with that. But it's not like a sexy thing, right? It's like,
right.
You have major heart problems and this is going to help your heart function, right? Yeah. And so I just kind of feel like we're using like a medical tool that treats a very narrow and important range of medical problems, right? And those medical problems are very big deal to people who have them. And I'm not a relativist about them, right? Like, it is not good to have a heart failure exacerbation.
Yeah.
It is not healthy. I'll say that, right? Like, talking about our definition of the word healthy. And these medicines can help, but it's not going to fix like all of our sort of cultural hang-ups and cultural shame about our bodies, right? And that, like, I don't like feeling like people are sort of coming to me for, something that like as a way of sort of perpetuating or hoping to avoid like discrimination. Yeah. Like it feels icky. Like, it feels like I'm selling Weight Watchers or something.
Right.
And as opposed to, okay, let's talk about these really useful things that these medications can do, but they're not sexy or exciting, right? They're like pretty utilitarian, right? It has to do with like adipose tissue in your liver, right? Like, no one can see it.
Yeah. And I think there's also a misunderstanding, like, any medication has side effects. And so like, if you're taking like anything, you're signing on for a lot of side effects. And of course that could be in your mind, better than things that you're experiencing in your day-to-day life. But it's just like, I am pretty medication averse in my own life, and I still take, things that I need to go to sleep and this and that. But boy, I really work hard not to take very many things, because I just feel like anything I add is like some weird side effect now, whatever. It's just like it's an X factor kind of outside my body. And we just live in such an obsessed society for like, fix this thing. And sometimes, you'll end up, I have family acquaintances who have like 18 pills they take. And I'm just like, does all the people prescribing this, have they all talked to each other? Like, you've got this person to do this.
Doctor. Yeah.
Yeah. Seriously. Yeah. Yeah.
But yes,
so,
I agree. And I think it's important to understand who's profiting, right? And again, I always say caveat, these are great medicines. I'm very grateful to the researchers who developed them, but like a lot of people are making a lot of money off of this, right?
Seriously.
And I just think that sort of the pharmaceutical industry is a very large force in our culture, right? And it rewards this kind of thinking, right? That getting on more pills is always good. And pill medicines can be so useful. I prescribe them all day, every day. That's a big part of my job, right? Is using medications to treat illness. But there's a lot of profit too.
Is there a scenario where you would not prescribe these, or had you been in a situation where you've said to someone, I don't think this is the right medication for you, or I don't feel that this is actually appropriate?
Yeah, I have. And usually those are sort of like ongoing conversations. I think a lot, if people have a history of a real clinical eating disorder, that's often a reason to sort of hit pause. And not that I've had people who I'm aware of having, major history of disordered eating asking for them, but I always just kind of try to check in about their mental health. That's one big category. BMI is bogus, but I've had people with a BMI under 25 asking for them too. And I was like, your insurance is not going to cover it. And honestly, a lot of people with much higher BMIs, their insurance doesn't cover it anyway, unless they have a diagnosis of diabetes. So this may change over time. I don't know. But I do kind of reject the idea that like anybody whose BMI is 26, I mean, that's considered abnormal, right? That's like the vast majority of us have a BMI of 26 or above.
Oh yeah. I actually recently calculated mine, and mine is, I'm in the high BMI because I'm a muscular person. So
totally.
Yeah.
So, I mean, that's vast majority of Americans. But yeah, I do reject the idea that like everyone needs to be on these medicines if their BMI is 26. But
right.
I think, yeah, I mean, it's just like, I'll be like, it's not going to be covered by your insurance, right? If your BMI is low. And those are sort of the big ones. I mean, people who have a particular family history of like a particular type of thyroid cancer really shouldn't take them, or if they've had pancreatitis, really shouldn't take them too. That hasn't come up that much. And because the thyroid issue is quite rare. It's like a particular syndrome of thyroid cancer, and it's really rare. And pancreatitis, I have more patients who've experienced pancreatitis. That's somewhat more common, but yeah, those folks really shouldn't be on these medications. And again, I'll often do this over the course of several visits, right? That's, to me, is the privilege and the pleasure of being a primary care doctor, is getting to know my patients over time. And so they'll say, oh, I want to take Ozempic, and we'll ask some gentle questions about like what their goals are. We need to get some labs to start. And then they'll come back and I'll say, like, how's, and then their goal for weight loss will often be more aligned towards actually trying to move their bodies more, right? So like they'll say, oh, I want to lose weight so I can keep up with my kids. And I'm like, actually, let's talk about exercise, right? And I don't care if you lose weight doing it, but actually regular movement is going to help you achieve your stated goal. Or I want to be able to, run up the stairs without feeling winded. And I'm like, girl, I hear you. I live in a 4-story house, and I'm like, ooh, my bedroom's on the 4th floor. It's if I try not to forget anything before I have to run out in the morning. But anyway, so I think I have these conversations usually over the course of a few visits when people have time to think about it. And I know, there's a bazillion telehealth companies people can go to instead of me. And
right, that's
a lot of my patients do. A lot of them do. It's not wrong necessarily. It might feel easier for them. Fewer questions asked. Yeah. And that's, bodily autonomy, right? Like that's their decision ultimately, as long as the doctor is providing the prescriptions are really doing no harm first, right? And they're doing their due diligence. But
which is questionable.
Yeah.
It's very complicated. You give me a lot to think about. I'm thinking, pressing pause on someone who has a history of disordered eating, and I'm thinking somebody who's coming in who wants to lose weight, it's highly unlikely that they don't have disordered eating. And I'm not saying that all larger bodied people have eating disorders, but probably a person who's asking for one of these drugs has a history of diets and weight cycling, which would suggest a not very healthy relationship with food. But that's also a symptom of our culture, an enormous lack of education around what a healthy relationship with food is. Capitalism, everything is delivered to our door, everything is cheap, crappy food that's addictive. Like, this is not the individual's fault, but wouldn't it be amazing if instead of these drugs being available with some online prescription thing, we lived in a society that valued giving people time off and time to eat lunch during the day and no emails after 6 p.m. and, basically the space and time to prepare dinner and sit with their family. And I would be really interested to see how these drugs are being used, or like what the popularity is in countries that have a more balanced relationship with food culture and just movement in general. I read Magic Pill, that book that came out recently about Ozempic, and he's
yes, I
like
do
very Johan Hari.
I haven't read it, but I heard about it.
He's a bit controversial because he plagiarizes sometimes. Yeah.
Oopsie daisy.
But there's a section there where he goes to Japan, and they don't have obesity apparently in Japan, like at any real measurable rate, percentage that we do in Western countries. I'm sure that's like, it has 1,000 caveats. But one thing that is very important in the culture is people get taught how to eat in school. They get a variety of things on their plate every day at the cafeteria. The kids take part in the food preparation and serving. They're encouraged to try new things. And it's like a very balanced plate with like fish and fruit and like a soup and all these different things. So as opposed to our American food system where, I mean, honestly, I remember I would literally have a little pint of milk and fruit and like a bag of potato chips for lunch every day because the lunch food was so repulsive. And, it's disgusting spaghetti or dry, gross pizza. And that was literally, I mean, we just got junk, like just complete junk every day.
Like I was talking to one of my coworkers, and she was worried because her daughter, who's like school age, wasn't eating lunch. Like the teacher's like, she's not eating, and it's because they had 15 minutes to eat lunch, and she wants to eat slow.
God, heartbreaking.
That breaks my heart. She's like 7. Yeah, totally. I share your concerns, and I think that that's why I come back to this idea of like justice for bodies, right? Like, what does justice look like? And justice looks like, where we all can afford fresh foods, right? Where we can all have access to vegetables. And like I said, I'm not a total relativist about all of this stuff. Like I cook my family food from the farmer's market or from Whole Foods, right? And that's because I can afford to, and I have time in my day to do so. And so, yes, a diet of all carrots, like we were talking about, would not be health affirming, but yes, like balance and having access to balance, I think is in almost every scenario sort of a component of what it looks like to engage in healthy behaviors, right? Balance for foods. And that's cultural. I mean, there's a lot of caveats, but it's still like, I think there's some core principles that I would feel comfortable hanging my hat on, right? That like, trying different food groups, trying a variety of foods, like having time to prepare our meals, having the ability to sit down with our loved ones and not eat in front of a computer, which I'm guilty of. I do almost every day. I eat my lunch while I'm charting. Yeah.
Your Amazon factory, warehouse patients, where does that leave them? Like, what does that lunch break look like? What does that commute look like? A person who's working like that is not stopping at the Wednesday farmer's market that happens from 1 to 3 on their way home.
Totally.
Yeah.
And this is where I think I diverge from some, fat positive circles that I've seen online, is that like, as a doctor, like, so yes, massive caveat that like health is very personal, and what it means to be healthy can change and evolve over time, may change, in the span of a day or two, right? Like, but I do think that if we evade the question a little too much, that we risk doing harm to people who are really vulnerable, right? Like I work in a food desert, like you cannot go to a corner store and find vegetables in the city where I practice medicine, right? And I think that and I guess this also comes back to the idea that like sort of a stereotype that like the body positive community is for like rich white ladies too, that like if we don't have these conversations about what it means to be able to access fresh food, if we don't have conversations about, physical space and time in our days to move our bodies. I mean, I can't tell you how many patients, I work multiple jobs, literally out of the house from like 5 a.m. to 10 p.m. every day, working for their families. Don't feel like it's safe to go to the park. Don't feel like it's safe to let their kids play in the playground. I think without acknowledging some of the injustice in like the systemic features in our culture, we run the risk of just ignoring the way that sort of access to healthy behaviors disproportionately affects, low-income folks, people of color, people who are marginalized in other ways, right? Yeah. So thank you for, it can feel hard to talk about sometimes. You know what I mean?
Yeah, absolutely.
Lest I be too healthist, right? That like, I'm saying that like carrots are healthier than cupcakes or whatever. And that's not exactly what I'm saying. Yeah, but it's also not, I'm not a total relativist about all of this. Does that make sense?
Yeah. Side note, I know I've kept you a long time and I want to ask 2 more complex questions. I've wanted to have a doctor on for so long. But little side note, I take issue with like some of the like activist movement. Virginia Soul-Smith, who I know you've been on her podcast, she often lately has been like on this whole like processed food isn't necessarily bad for you thing. But for me, in such a binary where I'm like, objectively speaking, a carrot is better than an Oreo. Like, you cannot tell me otherwise. I understand the bigger point you're trying to make is don't demonize or moralize the person who doesn't have access, lives in a food desert, and is trying to do the best for their family. We shouldn't be making that person feel like they're a bad parent or harming themselves. But it ignores the fact that these companies are preying on people and creating addictive food that has zero nutritional value and marketing it to people and giving them value meals and all these kinds of things, when it's very possible to get fresh food into bodegas if our food system valued that, if they cared about that. And so I think sometimes we get lost in the weeds of like exercising ourselves from diet culture and then almost like there's like no rules anymore. And I'm like, there's basic common sense of just like, let's use our meal times for food that's supporting us, which does not necessarily at all have to be restrictive or boring or look like some vegan plate of schlop or something. But yeah, like a lunch of Oreos is not supportive. It's just not supportive to your body. And I can't get behind that.
Well, and I think you're asking the right questions, which is like, what are these who's profiting, right? And I don't think big food is our friend, right? Like, I think that there are these big companies that are making a lot of money off of us. And yes, I mean, that's part of it, but also, how are they being subsidized too? Like, what are the systemic forces that is making it that I can walk to a corner store across the street from my clinic and you can find an Oreo, but you can't find a banana, right? And what are the forces that make that the case?
Exactly.
And so it's not that if you eat an Oreo, which are delicious, by the way, and I love eating Oreos, it's not that you should spiral into bodily self-hatred if you eat an Oreo, right? But yeah, like why are Oreos easily found and broccoli is not? And I think those questions are important to ask if we're going to be thinking about, how the most vulnerable folks are impacted by public policy. So yes, I agree that we should be looking at the sort of systemic forces, but that it can be harmful to be totally neutral about them because they affect people disproportionately, right? Like I can say, oh, Mara, like I'm empowered when I eat an Oreo because I can afford vegetables at Whole Foods.
Yeah, exactly.
Yeah. So I think being mindful of that is really, really important.
Exactly. I realized I used the word obesity recently, just earlier in our conversation, and I wanted to ask you had written about obesity medicine versus endocrinology, and kind of, I'm wondering if you could briefly explain to us the difference of those and kind of these terms around fatness, basically. And then my side question is, what is metabolic syndrome?
Oh man. Okay. So if you would like to apply to medical school, Cadence,
Seriously.
We would be thrilled to receive your application.
The rest I kind of want to.
I think you'd be a great doctor. I think, yeah, we definitely need more doctors who understand sort of physical components of medicine. I feel like it's a weakness of mine, honestly. And there is a field of sports medicine. So just saying. Anyway, so obesity medicine, I have to say, I wish I could prepare a little bit for this question because there's actually some history that I want to get into and I don't want to like misquote.
Sure.
So
you also have a little bit of a piece about it, which we can link to.
Yeah. Well, so it's more, I mean, I guess I was writing about what people are calling obesity first medicine. Mm-hmm. And so obesity medicine is a subspecialty and it has an association, like a professional society. I think it has a certification process that may be sort of governed by accreditation bodies in healthcare or in medical education. And basically it's like a certification that doctors, primary care doctors, internists, family doctors, I believe endocrinologists, once they're an endocrinologist can also get a certification in obesity medicine. And I'm not an obesity medicine doctor. I don't have that certification. And it is a field of expertise around treating obesity as a disease and helping patients fight it usually with medications. And it's sort of, I think the field, defines obesity as pathologic, defines it as a disease, and is dedicated to treating it as such. That is a little bit different from what I was writing about, which is obesity first medicine, which is not exactly like a certification. It's not accredited or anything. It's sort of like a practice framework where like I say like, I practice patient-centered medicine or I practice like I value patient autonomy, right? It's sort of like a framework of how doctors approach medicine. And it's recently gained some traction and, there's been some high profile articles about it in the news about doctors sort of with the advent of GLP-1 agonists moving to what we call an obesity first approach, which is basically like treating obesity as a disease and saying, I'm going to give you medicines to try to reduce your BMI as a treatment for all of these other medical issues, including, hypertension, diabetes, heart problems, things like that. And so they're related. I think the obesity first sort of practice framework was born out of obesity medicine as a medical specialty, but many doctors who are not certified in obesity medicine will practice from a framework of so-called obesity first medicine, where they'll say, hey, let's work on getting your BMI down. And I think it'll be good for you for all of these reasons, rather than sort of treating each issue individually. Is that clear?
Yeah, very clear.
Oh, and endocrinology is a medical specialty that's been around for a long time. I don't know. I mean, years and years and years. And it's like a subspecialty of medicine where you have to get additional training, additional certification, and like training in endocrinology. Like if you're a board certified endocrinologist, it means that you have taken an exam that is, approved by the Endocrine Society. And endocrinologists treat diabetes. Many of them practice sort of obesity medicine, but they also do a lot of other things like thyroid disorders, adrenal disorders, like other disorders of the endocrine system. So it's much broader than simply focusing on, diabetes and obesity. Is that clear?
Yeah.
That may have been a little more in the weeds than you wanted. But
no, I love that.
Yeah.
I love that.
Yes.
Yep. Can you briefly describe metabolic syndrome? Is it real? What is that?
Yeah. So metabolic syndrome is real. And I mean, what is reality? But it's basically like a constellation of symptoms where we see folks with basically, elevated blood sugar, often like what we call fatty liver disease, which we got to rename. It's like, sometimes you'll see it as like non-alcoholic steatohepatitis, which is like a mouthful. Okay. Basically means like fatty tissue in the liver. And it's basically where we see like inflammation and abnormal liver function relating to adipose tissue in the liver, which can be really, really harmful and can cause a lot of medical problems and is definitely, I see it all the time, not correlated with BMI, right? So people with sort of like a moderate BMI, like in the overweight category, can have a lot of medical problems related to fatty liver disease, whereas people with a very high BMI often have no evidence of this. So again, just coming back to the idea that like you can't visualize somebody's medical status just from looking at them, and it feels stigmatizing because fatty liver sounds like a stigmatizing diagnosis, but yeah, it can be quite serious. And people often have cardiovascular problems with this syndrome, and it's kind of imprecise. Like I tend to not use it in my medical documentation. Like I'll sort of document each issue separately. But yes, we often see those things together, and we often see them in people who don't have a high BMI.
Interesting. I totally thought that it meant that your metabolism is haywire in some way where you're gaining or losing weight regardless of your actual energy intake or output or something like that, that it was some kind of almost like diabetes like misfire happening, but it's more related to this liver.
Yeah, and it can be quite serious, and it's yeah, I tend to not use it like in the medical record just because I think it's more precise to sort of like talk about each issue one by one and talk about like a plan for each issue one by one. But it's just that all of our organ systems are interrelated, right? And we tend to see, in particular, I think we've really underestimated the liver. That's my hot take, that we really don't understand the way that liver function relates to insulin resistance. And then insulin resistance can cause diabetes, which can cause a lot of what we call like both micro and macro vascular problems, right? So diabetes can basically cause
I actually know a lot about diabetes because I had a diabetic dog that I gave insulin shots to twice a day.
Oh my gosh.
I know a lot about diabetes. I'm like a diabetes expert.
Bless you. Well, I'm not a veterinarian. I wish I were. I love talking to my dog vet about my hobby is like, but a human doctor and a dog doctor. Yeah, get him a couple beers. But anyway, yes. So I am sadly not a mad respect for
it's I really
and I have
like
species.
I vastly helped her diabetes by following human diabetes protocol, basically. So that's why I know a lot about it.
Yeah. And so I had a dog. That's a lot.
She lived her full life because I treated it correctly. And most dogs only live 3 years with diabetes, but I gave her insulin every day. We changed her diet. We like did the whole thing like she was a diabetic person.
It's lucky to have you. That's a cute story. That's funny.
But I interrupted what you were saying about the liver, which that is really fascinating because in Chinese medicine, traditional Chinese medicine, the liver is the king, and there's a lot of focus on the liver. So it's interesting that Western medicine, you're saying we've underestimated.
I mean, I talk to a liver doctor and they'll be like, no, it's the most important organ. I mean, I don't mean that people underestimate. I think it's more like in the popular conception of diabetes, right? Like I just think diabetes is such a stigmatized disease and we associate it with having a larger body size. And I think that there's a lot of complexity around like genetics and like the way that basically like the liver functions, right? And also the pancreas. I mean, all of these, it's all related. All of our organs work together, and to pretend like they're separate is silly. But I guess when I said we've underestimated the liver, I think I mean more in like the public consciousness, right? And
for sure. I think people only think about the liver in terms of alcoholism, basically. Right. Like that's the only way it comes up.
Yeah. But I think we can't really predict using BMI, or let me rephrase. I think BMI is a poor predictor of who has fatty liver disease, and fatty liver disease can be a predictor of severity of diabetes. And so again, it's really, BMI is just a very blunt instrument, and we fixated on BMI because it's sort of publicly visible, but again, it really doesn't tell the whole story. And I think genetics plays a huge portrait in who goes on to have really severe disease versus who doesn't.
Yeah, I totally agree. I could talk to you forever and ever. We should have you back to continue just answer our questions. I literally now I want to ask you how much, if you read Gabor Mate, and then we could just go on a whole other thing about genetics and environment and disease. To sum us up, what recommendation do you have for people with their primary care? Like how would you want people to approach their medical care?
That's such a great question. Thank you for asking. I think coming into it feeling like it's a partnership, right? And hopefully a long-term relationship, and that it's okay to advocate for yourself, but also that doctors are not Amazon, right? Like I want to have like a sort of rigorous and science-based relationship with my patients where we get to know each other over time. We trust them. We trust each other over time. And I trust my patients to advocate for what they need, but also understanding that, yeah, like it's not going to be a button you click and you get a pill that fixes all your problems, right? That we're going to work together. And sometimes that work is really hard. It's not always easy and quick. And yeah, so I think coming to it with that attitude of like, this is what we hope is a long-term partnership where we can support your health and well-being over time, however you define it and however that definition evolves over time. But yeah, this is not like Doc in a box, right? It's not a button you click to, get whatever you need delivered to your door within 24 hours too, that this is hard work.
I would add to that and kind of bringing us back to the beginning of the conversation, in any relationship, you're building trust, and people have experienced so much harm and shame around their bodies, potentially, especially in the medical world. I would add, don't hide things from your doctor, because I've experienced, and I'm sure you've experienced, I've experienced people like 6 sessions in, they're like, by the way, I had spinal surgery or something. I'm like, what? Why didn't you tell me this on the first day? But you're asking someone to come in, they're already going to get like poked and prodded. And I know some people hide things from their doctors because they don't want to be chided or they feel ashamed. But, I would encourage people like find that doctor like you who's open, who's listening, and then really tell them so they can help you what's going on. Tell them if you drink a bottle of wine every night. Don't hide that. Like you might say, okay, let's look at that. But my goodness, if someone's prescribing you medication, like don't hide that you stay up all night playing video games and actually only get 2 hours of sleep, or like, are having panic attacks or something. Because I think so many people go to the doctor like they're going to the principal and they're like, what can I get away with almost? And I totally get it, because people, like you said, are literally getting yelled at for being fat. So, it's hard. We usually know what our bad behaviors are anyway. So it's hard to be like, well, I actually stay up till 2:30 every night and like blah, blah, blah. Tell your doctor, because they're literally they're like there to help, hopefully. And if they're not, find a different doctor.
Totally. Yeah. And I like what you say. I mean, I've really been reflecting on that recently, like the idea that going to the doctor is like going to the principal's office. And I really want to work to undo that. And it's hard. I think it's just so ingrained in our public sort of consciousness about what it means to have a primary care visit. And that's not why I went into medicine. It's not an awesome feeling for me to feel like I'm your principal. But so, yeah, I think self-advocacy is absolutely appropriate, and sort of communicating what your needs are, right? Like if you don't want to be weighed, tell me, right? And we'll talk about it. And that doesn't mean that I'm always going to agree, but we can have a respectful adult conversation as sort of, as partners, right? The idea that the power imbalance is so profound. Like I never want patients to feel that way. And if you're made to feel that way in your self-advocacy efforts, you should find a new doctor. But also that it's unlikely we're going to be able to fix everything immediately, right? And sort of coming to it with like the way that you'd approach the development of a long-term relationship is what I would recommend.
Yeah. Beautiful. Thank you so much. This was so fun.
Such a pleasure to get to talk with you. You are doing the Lord's work with, just making exercise and movement accessible for all folks. It's so, so, so important. So thank you for what you do.
Well, thank you. I mean, you're slowly restoring my faith in doctors through this conversation.
Well, thanks for everything. Stay in touch.
Thank you. That was Busybody Podcast. I'm the founder and owner of Brooklyn Strength Studios. You can find me on Instagram at Brooklyn Strength. You can find out more about my offerings on my website, brooklynstrength.com. I hope you'll subscribe to my Substack after class. All's in the show notes. Please rate, review, and subscribe. Please share with your friends so that more people listen to this podcast. I love these conversations, and I hope more people can hear them. My music is by Rob Byrne, performed by the Wild Yaks. My podcast is produced by Brad at Soundtrain Studios, and my illustrations are by Jackie Mendez and Azul Trejo, and edited by myself.
Thank you so much.